So now we're going to talk about signs of shock, and then I'm going to correlate them to symptoms over on the right side, but signs of shock. And I want you to know about 5 of them. And one of them happens early, and one of them happens late, and then 3 of them happen together, kind of in the middle. And we'll kind of explain how this happens and why it happens, and I think it'll help you remember it. So the first sign of shock we're going to call altered mental status. As your brain gets starved for blood flow, and therefore starved for oxygen, your brain is hypoperfused, it doesn't act right, and so you have altered mental status. Now that's hard to assess, because a lot of people show up at our calls with an altered mental status, and it's not from shock. There are many causes of altered mental status. Matter of fact, we use a mnemonic that we'll talk about later called AEIOUTIPS, so I think that's 10. AEIOUTIPS, 9. There's at least 9, and some of those can count for multiple things. So there's around a dozen causes of altered mental status. Shock is just one of them. Hypoxia, low oxygen to the brain, is just one of them. It's the first one to show up, but it's the hardest one to detect. Okay? The last one to show up is hypotension, low blood pressure. That's easy to measure. You measure that in your initial assessment, don't you? There's no blood pressure cuff out in your initial assessment, but you're estimating their blood pressure by checking for radial pulse. Patient has no radial pulse, he has hypotension. Okay, that's an easy one to guess, easy one to assess, but the last one to show up. The 3 in the middle are all related to your body's compensation mechanisms for reduced perfusion. Okay, and as Sarah was talking about, there's a couple of things in there. So to understand this, I want to briefly explain how your body works on this deal. Your body has receptors in the aorta, in the brain, that monitor perfusion, monitor pressure. And when those pressure sensors note a reduced pressure, they send a message to the brain saying, pressure's low, pressure's low. And brain says, okay, I know what to do with that. I'm going to do several things, not just one thing. But if you have a system that has a pump, and it has some fluid volume in it, and it has a container space, some pipes and such, and you want that pressure to go up, what can you have the pump do? If you want the pressure in your system that's got a pump attached to it, if you want that pressure to go up, you want the pump to go faster and pump harder. Okay? So your brain sends signals to your heart through various ways to increase its rate and increase its strength of contraction. So one of the first things we'll see is tachycardia, an elevated heart rate as the brain attempts to get the pump to pump faster to keep the pressure up. Now, if the whole goal here is not just to deliver blood to the tissues, but it's to deliver blood packing a bunch of oxygen to the tissues, where else would the brain go for some help when it senses shock? So it's cranked the pump up, but we need to crank the respiratory rate up also in order to bring in more oxygen to load onto that blood to circulate around. Whatever blood you got left needs to be really jammed full of oxygen because you don't have your normal amount for whatever reason. So a rapid respiratory rate, and the medical term that we use for that is tachypnea. Those are 2 signs you will notice right off the bat in your initial assessment. So can you see how already, without even talking about the last of those 3 in the compensation trio, already your initial assessment is giving you a good assessment for shock. You're checking altered mental status, you're checking radial pulse to see if there's hypotension, and you're checking for a radial pulse for rate. If you can't find a radial, you're going to the carotid. So you're getting a heart rate, a respiratory rate, a level of consciousness, an estimation of blood pressure. Your initial assessment is really a pretty good shock assessment. All right, so then there's one other thing that the brain knows to do. When the brain gets the message from the sensors that the pressure's dropping, the brain says, well, if I want to keep pressure up in my system, I got to pump faster and pump harder. I'm doing that. I'd also like to reduce the size of that system if I could, because the smaller container with the same amount of volume is going to have a higher pressure. Just kind of makes sense. So the cool thing about your blood vessels is that they have muscular walls. And they can constrict, get smaller and make the container smaller, or they can dilate and relax and make the container larger. And they stay a little bit constricted all the time, as long as the brain is sending them those signals. But blood vessels are like medics. Blood vessels would rather be relaxed with their feet up doing nothing than have to be doing some work. So unless the brain stays on those blood vessels to stay a little bit constricted, they look around, the boss is not telling them to stay constricted. They say, put their feet up. They relax. The absence of cerebral control, the absence of nervous system control, is going to have vasodilation. That's another kind of shock that we'll talk about down the road. But it's not the kind of shock that we'll typically see out here today with your motor vehicle crash driver. So we're going to talk about the brain's ability to say, not just stay a little bit constricted, but constrict a lot. And so when the brain senses, when the brain gets the message from those sensors that pressure is dropped, the brain sends a message to the heart to pump faster, stronger, a message to the diaphragm and the breathing mechanism to breathe faster, and it sends a message to your blood vessels to constrict. And so when you get that, the sign that you see is typically cool, pale, and clammy or sweaty skin. That's the sign that you see. The first one comes on right away, but is hard to assess. The next three come in together. It's because the compensation mechanism is kicked in. The brain has been told the pressure's dropping. It says heart beat faster and stronger, breathe faster, and let's constrict those blood vessels, and let's send less warm red blood by the periphery. And so when you're assessing skin out here, it looks pale because there's not much red blood going by. It feels cool because there's not much warm blood going by. And those two things together, plus the sympathetic nervous system, makes you a little sweaty and clammy. You don't have to have a blood pressure cuff. You just have to have your eyes and your hand in about 30 seconds. And you've figured out shock or no shock present yet that I can detect. Pretty straightforward. And then you, of course, would check that radial pulse, and if hypotension has shown up, then you've already had altered mental status and the other three together, and now we've got shock. So there's the signs, okay? All right, so we had signs, and then we have symptoms. And what's the difference between those? What's the definition of signs versus symptoms?
Signs are something you can visualize or find, and symptoms are something that they're describing.
Right, so signs are things that you see and feel. Symptoms are things that they feel, they tell you about, okay? So your first sign of shock would be an altered mental status. What would the symptom for that be?
Level of consciousness.
They feel anxious. They feel confused. They feel scared. They feel something. Their brain's not working right, and they know it, and they express some anxiety. Sometimes people will call it a feeling of impending doom. In other words, they know things are about to go bad. They're not really sure why, and they feel that. Then the next one is a tachycardia. And so what would the symptom be that they would feel when their heart is beating rapidly? They would feel their heart beating rapidly, right? They might feel palpitations or their heart's pounding or something like that. So they can feel their heart. And then an increased respiratory rate, which they're going to feel a little bit short of breath. And then they're going to have the skin changes, cool, pale, clammy skin. And sometimes they will feel cold, or they will feel that they're, drenched in sweat. And then finally, hypotension shows up as a sign, and they will feel potentially lightheaded, dizzy, something like that. Make sense? 5 signs of shock, 5 symptoms that go along with it. Okay? Body's compensation mechanism kicks in and produces the middle 3. The first one's real subtle, the last one's real obvious. Okay? So that was assessment of shock, and now we have 5 treatments. And you've already been doing some of these, and you'll just kind of do these naturally, but there's one that we tend to forget. So one of the most obvious ones is to control external bleeding, and you sometimes do that by managing injuries. If you remember the analogy of the guy who wrecked his truck and had the tib-fib fracture that was leaking some blood, you control that. That kind of helps control bleeding, or you control bleeding. That one's kind of obvious. Then if a person has decreased perfusion and they're not able to get blood to the tissues like they'd want, and they're going to be breathing faster in order to bring in more oxygen, what do we have that we could kind of add to the mix here that might help? Okay, so O2 is very definitely where we're headed. Then what body position would be best to help this person with their blood pressure? So would a standing position, sitting position? So what we want you to do is lay them flat. We do not want you to put their head down and their feet up. We want you to lay them flat. The standard for shock treatment is place your patient supine. The reason that the head down doesn't work as well anymore is that it impedes their respiration. If this afternoon we were to put you in a head down, feet up position on a backboard, you would find it harder to breathe. And it doesn't do that much more for your blood pressure and your blood flow to your brain. And so we can get pretty good effect of laying you flat without the side effect of putting you on your head. Okay? So we're looking for place them supine. Then where do you think shock is treated? This kind of shock. Blood loss shock, trauma sort of shock. Not anaphylactic shock from a bee sting, or septic shock from an infection, or cardiogenic shock from heart attacks, or any of the other types of shock that's out there. Where do you think this kind of trauma-related, low-on-volume shock, is that treated in the field? No, that's treated at a trauma center. So how do you get your patient to the trauma center? Fast. And why does the ambulance have wheels on it? They're supposed to go round and round. Okay? So rapid transport is the key. And I'll bet you could have guessed most of those. Some of you were not so happy with the supine, but you were going to position the patient. Okay? And the O2 and the control of the bleeding, I don't think that's rocket science. This last one's not rocket science either, but we don't do it very well. We tend to forget this. What do you think the 5th one might be? Keep them warm. Keep them warm. So there's your 5. You've got 5 signs of shock. Altered mental status, tachycardia, tachypnea, cool, pale, clammy skin, those all come together. Hypotension comes last. You've got symptoms that match up with those. They may be anxious, they may be lightheaded or dizzy, they may feel their heart pounding, they may feel short of breath, they may feel cold. All these things add up to it. And then your 5 treatments, which you've been doing in scenarios up to this point for the most part, lay them flat, move them quickly with O2, keep them warm, and controlling that external bleeding that you can get to.